So hi everyone, my name is Alex and I'm presenting today with Matt. As Kat's already said, we are part of Swansea Bay University Health Board. We're part of a care home team and we've just been asked to present today on how our work feeds into the NPIs and also how the NPIs inevitably feed into our work. And like Kat has already said as well, the whole team is here today. So if you've got any questions, feel free to pop them into the chat and we'll try and answer as many of them as we can at the end. So just a little bit of background about the team. So a little while back, as a medicines management team, we reviewed our elderly care focus in the community, and we wanted to ensure that as a medicines management team, we provided excellent pharmaceutical support to the whole population of elderly patients within our health board. This was already the case, but we wanted to strengthen and enhance the service that we were already providing to them, and care homes seemed like an obvious starting point for us as a team. So we compared the pharmacy support that our 4 acute hospitals received in our hospitals, and we compared this to the 140 care homes within the community. So despite this, the actual pharmacy team provided to care homes wasn't quite what we thought, and especially when you consider the outcomes of the Healthier Wales report, which suggests that more care should be undertaken within a patient's home or a care home in this case. Our aim was to strengthen the existing pharmacy support provided to these patients in care homes. Initially, the idea was to just employ more clinical pharmacists, and this was very tempting. But when we actually sat down and thought about it, and thought about what the benefit that we wanted for the patients, we realised that the medicines management team is much more than just clinical pharmacists. Obviously, we couldn't entirely replicate the pharmaceutical care given to patients on the wards at our acute sites, but given the similarities between the patient populations between our care homes and our acute sites, we asked ourselves the question, what could we learn from the care provided in the hospital, and how could this be translated to our care home residents? So we then reviewed our experience of medicines management in the community, focusing on care home patients specifically, and we put the patient at the centre and reviewed all of the stakeholders and considered how kind of in their day-to-day practice they affect the care home resident. We reviewed what we knew from past audits, from enhanced service outcomes, and also through discussions with long-term care. And our overwhelming sense from this review was that the system for ensuring that the right patient got to the right patient at the right time was not quite as robust as we would have liked. We felt that you could spend a huge amount of resource diagnosing and prescribing, but if that medication didn't get to the patient in the right way and in the right time, the effect of any clinical intervention would have been limited. So we decided to target the underlying medicines management system and processes that we felt needed strengthening. And in other words, we started from the bottom and worked up and reviewed the entire process given to these care home residents. We wanted to strengthen the medicines management foundation that everything else depended on. So through the movement of staff and promotions, an opportunity arose to support medicines management in care homes. And we looked at the triangle of issues as we saw them and asked ourselves where best to target our efforts. Which target would offer us the maximum benefit for the highest number of. Then thought about how this works in the acute setting and realised that if we were to apply the proven healthcare principles, we should consider ATOs as part of the model. So as a medicine management team, the aim was to begin emulating the breadth of what an acute pharmacy service already had in terms of staff groups. So we employed 2 ATOs to tackle the core medicines management issues such as medicine ordering and stock management. And we then employed a senior technician to project manage the care home support, to provide oversight of the ATOs and to tackle more complex medicines management technical issues that would inevitably require a technician to complete. So having the ATOs allowed the technician to spend more time on the technical medicines management side of things, and the ATOs were able to focus on the waste management side of things. And finally, we employed 3 clinical pharmacists to strengthen the clinical pharmaceutical support provided to these care home residents. So just a little bit of a timeline in terms of how our team came to be. So the ATOs were due to start in March 2020, but this was when the first wave of COVID struck. And we then redeployed these staff members to the acute sites in line with what other health boards were doing at the time. And the ATOs commenced work within the acute sites in our health board. providing support and were upskilled in the process as they weren't from pharmacy backgrounds. We then continued appointment as best we could, and our team was fully functional by September 2020. So the team has only really been in place for around 8 months. Then the second peak of COVID hit, but this time we realised how crucial it was to continue providing excellent pharmacy support to our care home colleagues. This time, staff weren't redeployed to the acute sites, as we did feel that it was a priority to keep them in the care homes to provide in support. And then finally, we have just recently appointed a consultant pharmacist with an aim to provide strategic direction to the frail elderly population in our health board, in addition to forging close links with the new Swansea University Pharmacy School, in order to develop and promote evidence-based outcomes for our patients. So we thought long and hard about kind of one sentence that would sum up the aim of our team, and this is to empower care home staff to provide a safe and effective medicines management service for their patients through collaboration with ourselves, community pharmacies and GP practices. So we really wanted to focus on 2 words in this theme, and that's empower and collaboration. So for the empower focus, we knew that any change needed to be sustainable. We couldn't just take over. So we needed to empower the care home staff to sustain the improvements that we made to their medicines management processes. And in terms of collaboration, we really did want to bring all of the key stakeholders together to understand each other's parts and how they played in each patient's care and how one can have a ripple effect on others. So building a collaborative approach through helping each other was our aim, to understand everybody's issues, needs and limitations in the whole process. So this is the team. So we've got Mazen and Garen in the top row on the left, and there are ATOs. Kerry on the top right is our technician, and in the bottom row is the 3 pharmacists, so myself, Matt and Rhiannon. So one of the unique aspects about this model of working is the level of integration that we have built into every team post. So the pharmacist's roles are deliberately built in integration to areas of acute care relevant to our care home sector work, i.e. the acute mental health and the acute frail elderly sector. So as part of the integrated mental health role, Rhiannon works with the care home in each team locally by being able to observe and review residents in this everyday environment. This can give the team a better idea of how their behaviours are in their kind of natural environment, and kind of allows for a more patient-centred approach. So with an aim to focus on more non-pharmacological interventions as a first line, according to the Bamsey report. Rhiannon's been able to integrate with the MDT closely and work with the consultant, both offering advice on pharmacological interventions and also referring residents to the MDT as she sees fit. This has provided her with a unique position to gain the knowledge and expertise to encourage reviews of antipsychotics in our care home population, as well as the wider elderly population, and this will inevitably feed into the NPI work that we're all trying to work towards. My integrated role is split between primary care and East Petolba Hospital. This is an acute site with a largely elderly population. My role mainly involves carrying out in-depth medication reviews with a focus on polypharmacy and de-prescribing, both in the inpatient and the care home setting. In addition to this, by optimising frail elderly discharges, I've hopefully been able to streamline a transition of care between sectors, something which has been identified as an area of improvement across the entire NHS. And working across sites has allowed us to have a greater understanding of the whole healthcare model and apply this where needed to meet the needs of each patient that we come across. Matt is the final integrated clinical pharmacist of the team, who works across GP practices, community pharmacies and also care homes, completing clinical reviews for care home residents. His work also involves working closely with technical services to provide clinical input and aiding the implementation of medicines management solutions in each care home that he works with. So not only are the pharmacists integrated, the technician is too. So Kerry has worked in primary care for a number of years and is able to use this experience to provide invaluable insight into how primary care is organised and how to best liaise with the GPs for all the patient's benefit. Not only this, but Kerry was one of the first technicians within our health board to implement medicines management at ward level, and this experience has undoubtedly helped in the implementation of medicines management in the care home setting, of course assisted by our ATO colleagues. So the importance of this integration was highlighted recently when a patient missed a dose of lamotrigine due to an inappropriate formulation switch. Matt was able to use clinical knowledge to liaise with the GP, community pharmacy and care home to obtain a readily available dispersible preparation which prevented any further missed doses of this critical medicine. So this integration is also reflected on both the local and national scale. So we've established excellent links with our pharmacy colleagues throughout the health boards. We actually met them this morning before this presentation. And the reason for this is kind of to find a universal way of working to provide seamless care again across sectors. So it's running the theme throughout our work. We've also made links across Wales through the National Care Home Forum for the same reason. And this has allowed us to explore work carried out elsewhere, highlighting the need for improvement and to implement these kind of solutions where appropriate. So hopefully you can see here how each member of the team works together to meet the needs of the patient at the heart of our operation and work towards those NPIs. So I'll just hand you over to Matt, who is sat next. Thank you.
Thanks, Alex. So how does our work complement the current national prescribing indicators? So by maintaining a holistic patient-centered approach when reviewing care home residents, we've been able to impact a number of NPIs by embedding them within our reviews rather than targeting a specific indicator. So by promoting and sharing good practice alongside this through our integration across both the primary and secondary care multidisciplinary teams, we've also been able to have an indirect impact on the national prescribing indicators. So when we think of our classic care home resident, they have multiple comorbidities and are likely to be prescribed a large number of medications. So by placing these residents in the centre of our review, we are able to target those NPIs specific to this resident when completing a clinical review for them. So atrial fibrillation is one of the morbidities that we would consider in this patient. So within Swansea Bay, GPs are signed up to the local enhanced service to provide DOAC initiation and monitoring for all patients, in addition to anticoagulation with warfarin. So by maintaining our patient-centered focus around this NPI, we would firstly ensure that a CHADS-FAST, but also a HAS-led score has been documented clearly and is up to date in the GP record. This would allow us to check if an anticoagulant is indicated for the resident and ensure that all appropriate monitoring is complete, in particular looking at the DOACs. And where no anticoagulant is prescribed or the dosage is inappropriate, so perhaps there may have been a change in the resident's condition since the last time it was reviewed, we can then highlight this onto the GP for consideration. So having a clinical pharmacist undertaking a review of a resident's medication has demonstrated a particular benefit in some care home residents during the COVID period. So we've complemented the monitoring of DOACs already carried out by GPs. So for example, due to significant staff isolation and sickness in local care homes, Alex was able to identify residents in need of further blood monitoring and managed to work collaboratively with both GPs and district nurses to ensure appropriate safe outcomes were achieved. So by being able to prioritise these residents for blood tests, Alex could ensure our patient-centred approach was maintained and the anticoagulation doses were up to date and correct. It's also had a positive impact locally by highlighting to other healthcare professionals the benefits of having a clinical pharmacist within their teams. So if we again look at our classic care home resident, they're prescribed a large number of medications. With these medications that are prescribed, there's often a risk that some may be inappropriate and could cause problematic side effects. For example, residents with a high anticholinergic effect on cognition or AAC score are likely to have an increased risk of falls and confusion due to inappropriate polypharmacy. So within our reviews, we assess AAC score for all residents regardless of their age. And from this, we can then identify residents with a high AAC score of 3 or more, in particularly looking if they have any medications that score particularly highly. And from this, we can then closely scrutinise the medications using tools such as stop-start to identify appropriate indications in the resident's past medical history. And from here, we can either stop the medications if they are no longer indicated, or if we do find an appropriate indication present, we can ensure that the lowest effective dose is being used, or discuss with the team potentially switching to a lower impact drug with regards to AAC scoring if this is appropriate. So one example where we've been able to apply this principle from our reviews is around incontinence medications. So residents are often prescribed these medications which can carry a high anticholinergic burden. and have often been prescribed them for a number of years. And then when we come to review the resident and discuss the resident with the home, we find that they may have deteriorated further and are now fully incontinent and may use pads or a catheter has been inserted. And this isn't always communicated to the GPs. So we can usually stop these incontinence medications due to no ongoing benefit for the resident. And again, this also has a positive impact on them. So by stopping these medications, we can reduce their falls risk if they are still mobile, help improve cognition, and often most important for care home residents and patients in general, reduce the number of tablets they have to take overall. So from identifying this work, we hope to collaborate with the incontinence team in the future, which will help allow us to identify those residents that are needing and using incontinence products, but also help us identify those that need a review and may be prescribed incontinence medications inappropriately, affecting their anticholinergic burden. So looking at this classic care home resident one final time, they may typically have dementia or cognitive impairment. And these residents can also often have behavioural and psychological symptoms associated with this, such as agitation or sleep disturbance. And this can often lead to the prescribing of antipsychotic medications, as well as hypnotics and anxiolytics, which we should only prescribe for the short term. These are often initiated by specialist mental health teams, such as the Care Home In-Reach team, and then referred back to the GP, where sometimes there can be a reluctance to alter these medications, particularly with care home staff pushing for residents to remain on treatment for a longer term due to concerns that they may become unstable again. So within Rhiannon's integrated role with mental health, this has meant she's linked in closely with the Care Home In-Reach team and provided support with reviewing these residents on long-term antipsychotics, and also being able to highlight those residents that maybe aren't so well controlled for a further review with the team. And this has been reflected through ongoing audit work she's supporting for residents that have been prescribed antipsychotics for 2 or more years. So out of all the residents that have been assessed so far, half of these residents that have been identified and reviewed by a consultant psychiatrist have been trialled with a reduced antipsychotic dose successfully, or have actually managed to stop the medication altogether. So Rhiannon's able to provide support with this by reviewing residents and help the MDT to create suitable reducing regimens for them. And again, this has a positive impact overall by reducing the risk of the negative impact of antipsychotics such as stroke and potentially improving the residents' health. And as a team overall, we're also able to support this process by providing support and encouraging ongoing review of antipsychotic medications and ensuring that all monitoring remains up to date. As well as this, we can support care homes through reassurance when dosages of antipsychotics are amended to ensure that we keep the resident at the centre of our focus and achieve the best outcomes for them. And this has been transferred into our work across looking at hypnotics and anxiolytics also. So because our ATOs and technicians work regularly in care homes, they can often help identify these residents where issues can occur with these medications. So for instance, they may highlight where residents are missing Zopiclone frequently due to already being asleep at night, or lorazepam hasn't been used for a long period due to the agitation symptoms being controlled appropriately. This can then be flagged up to us, and as pharmacists, we can again provide assistance here by reassuring care home staff and highlighting these medications to the GP for review to ensure that we keep the resident at the heart of our review and achieve the best outcomes for them. So it's more of an overarching area we've had input with. We've also been looking at promoting good antimicrobial stewardship and practice. So we've been able to identify those residents through our reviews, in particular looking at things such as long-term antibiotic prophylaxis and encouraging review here to prevent unnecessary prescribing. So by working with our GPs and our antimicrobial pharmacist colleagues in primary care, we've been able to highlight those residents that have been put on long-term antibiotics and ensure that these are followed up and we can stop them where no longer indicated. One example of this is Alex encountered a patient during his reviews that had been prescribed a low dose of nitrofurantoin for many years and couldn't see any clear documentation of review. So a recent update to our local antibiotic guidelines suggests stopping prophylactic antibiotics after 6 months. And this was a catalyst to having this low dose antibiotic stopped, reducing the risk of the resident developing a drug resistant UTI, while also reducing their tablet burden. And this work's also been transferred into those residents requiring acute antibiotic courses. So by attending ward rounds, we've been able to guide the multidisciplinary teams to ensure that local guidelines are followed and antibiotics are reviewed on an ongoing basis. So this work with the MDT has also been complemented with ongoing work in the care homes, where we've been helping to facilitate education sessions. So by working with our antimicrobial pharmacist colleagues in primary care again, we've been able to help facilitate sessions around UTIs. And we've been focusing on looking at things like diagnosis, differential diagnosis, and initiatives that have successfully reduced UTIs in care homes. And by providing these sessions, we've had feedback from the care home staff feeling that they felt more empowered and confident in handling UTIs. And again, all of this comes back to the resident, and it has a positive impact on them by ensuring that they are treated appropriately and only when required. And if antibiotics are required, we are given them the most appropriate treatment. So the final NPI that we'd like to discuss around is around PPIs, and this is an area which has historically been quite difficult to impact on, as well as more recent supply issues with other medications such as ranitidine. So they can often be quite difficult to reduce and stop due to multiple indications being present in a patient's notes, and sometimes a reluctance from the patients as well to stop or reduce them. So we've been able to work as a team to try and augment this work by working with the GP practices and reviewing notes in depth as to if there is still an appropriate indication for PPIs. So where there is an appropriate indication for ongoing PPI use, we ensure that the resident is on the lowest effective dose and the most appropriate drug of choice. So in particular, looking at formulation and cost. So for example, we review if dispersible preparations are still required, and switching back to capsules as appropriate, because sometimes we find that this isn't appropriate. But if there is still an indication for dispersible preparations, by making sure we choose the most cost-effective preparation. We are also able to highlight any possible interactions with any other medications and ensure that these are managed appropriately and monitored by the GPs or other healthcare professionals if appropriate. So where we find no appropriate indication for ongoing PPI use, we've also managed to have a positive impact by discussing with GPs and care home staff around reducing and stopping medication. So as I've already mentioned, this can be quite tricky. So by implementing reducing regimens and discussing this, we can ensure that all parties are happy with the end goal, and kind of looking at ongoing monitoring. We can carry on following that with the care home. And we find that if there are any kind of rebound symptoms that do occur, we can make sure, by linking in regularly, these are managed appropriately. So for instance, we may advise to use PET-TAC from the homely remedies if they have an SOP in place, or we can ask the GP to prescribe it as required. It's also really important to note that we're not just trying to stop or reduce all PPIs. We've also routinely advised GPs as part of our reviews to initiate PPI where indicated, such as an SSRI being prescribed alongside an NSAID. So although weight management does not fit any of the NPIs directly in terms of the goals, it fits the overall ethos of the NPIs, and it's just as important to improving prescribing practices, and most importantly, medication safety for the residents. So by working closely with care homes and improving medicines management practices, we've been able to directly impact care home residents by reducing waste, but more importantly, improving safety. So this is shown on screen now, where this was a picture we took from one of the care homes we've been doing some work in. So in this picture was the waste recorded from just one medication cupboard we found in the home, where they had 4 medication cupboards in total. So as you can imagine, there's quite a lot of waste that we found. So far the teams visited 3 care homes in Swansea Bay, and we've recorded £17,000 worth of waste. And of this waste, we found that 95% is avoidable. And again, this highlights the massive impact we can have as healthcare professionals in reducing waste. So such examples we found around avoidable waste is incorrect storage of medications. So in particular, we found things such as insulin, and also maybe less frequently used medications such as amlodipine liquid, which are stored at room temperature instead of being kept in the fridge. Another common thing that we found is often medication orders are rushed, and therefore staff may just order all medications without assessing what they actually need for the resident due to ineffective ordering processes. So this was reflected when we found one resident in a care home had in excess of 10 litres worth of paracetamol, which they just weren't using and hadn't used, I think, for 5 or 6 months. And then the other common issue that we find is around stock rotation being poor. So with new stock being taken in from the pharmacy and just being placed on top of old stock, meaning that stock can often expire unnecessarily without being used. So by working with the care homes and looking at these issues, we are able to promote patient safety and ensure that residents are getting the right medication at the right time. Feedback that we've had kind of from working with different teams kind of around the work we've already done, just to hopefully show you kind of the positive impact that we've had. So care home staff have felt empowered to build on the medicines management foundations our team's already built, and have an improved confidence when handling medication. So when speaking to GP colleagues, they stated that our usual commitment to care home reviews has been restricted. We are grateful for the help in independently reviewing and rationalising patient care. Within 2 weeks of being involved in the ordering process, staff at the community pharmacy fed back that they had noticed a reduction in medications ordered. And finally, from working with the care home in-reach team, they've stated the ability to access an up-to-date medication history completed by the pharmacist, and having this pharmacist to advise accordingly regarding current medication makes the pharmacist an essential resource in building a picture of the person. So in our short 6 months, we have had a significant impact on the key stakeholders and plan on cementing this further in the future. So looking towards the future, we've got a number of ideas as to how we can continue to embed the NPIs within our work. So firstly, we are soon hoping to complete our IPs as pharmacists, which would enable us to set up clinics for care home residents, allowing us to target more specific areas around NPIs to further supplement our work ongoing in the care homes. As a team, we have a focus on elderly care, and therefore we hope to extend our work beyond the care home setting and into the wider elderly population. So this will also be helped by the appointment of a consultant elderly care pharmacist to help direct this work. So we hope to continue to work across the multidisciplinary team in both sectors, working on areas such as continuing to make links with new teams and help provide further education sessions, not only just in care homes, but in other areas also to continue to improve patient safety. And finally, we hope to continue our work reducing waste and improving medicines management in care homes by looking at implementing new initiatives such as bulk prescribing of common medications. So I hope you enjoyed our talk.